Hi, everyone, and welcome to today's live from Cleveland Clinic broadcast. Thank you to all of the people who are attending today. We're very excited that you've registered for today's event. There are 900 healthcare providers registered from over 80 countries. We're so glad that you're here. We want the session to be interactive, so please provide your comments and questions as we go through. I'd like to take a moment to acknowledge and thank our sponsors of Cook Medical, Janssen Biotech, Medtronic, and Olympus. We'll start with our faculty introductions. My name is Claire Jansen-Odell. This is Alberto Rubio Tapia. We are also featuring tonight Andrew Ford, David Gardinier, and Kendra Weekly. With that, we will dive right into our first presentation. Dr. Rubio Tapia, take it away.
Thank you, Claire. Welcome, everybody. The first presentation is where are all these patients with celiac disease? And my name is Alberto Rubio Tapia, and I'm the director of the Celiac Disease Program. I have nothing to declare. And we have three learning objectives. First is our outline of the epidemiology of celiac disease. We'll describe how to unmask the hidden epidemic of celiac disease, and we'll review the multi-system clinical presentation of celiac disease. And let's start with the facts. Celiac disease is very common worldwide. Biopsy-proven celiac disease is 0.7% of the population. And if we use a serology-based screening program, it's about 1.4% with regional variations. But the big problem here is that undiagnosed celiac disease is about 83 to 95%. So we need to find those cases to be able to impact the lives of those patients. But where are those patients finding? Where are those patients hiding? In this study from 2012, we know that in the US, almost 1 in 141 are affected with celiac disease. That means that the patients are around us. They also try to be diagnosed. And it's helpful to know this epidemiology, the celiac iceberg concept. In this concept, diagnosed cases are at the top of the iceberg, and most of those cases have the classic presentation of diarrhea and weight loss, but we also have some cases with no classic presentation that we will talk about later. However, the area of the iceberg that we cannot see, and is the biggest area, it remains to be diagnosed. In this experiment in real life, from the Olmsted County in Minnesota, we found in the 90s that only 28 patients in a population of about 100,000 were diagnosed. And all of them have diarrhea as clinical presentation. We didn't know at that time, the size of the undiagnosed portion of the iceberg. If we jump to 2018, you can see that the diagnosed portion of the iceberg has increased from very few patients to about 410. Only 30% of those patients have diarrhea. That means that the vast majority of the patients with diagnosed celiac disease have a non-classic presentation for the condition. And then looking at the population level, we tested about 48,000 of the 100,000 residents of this area, and we found a prevalence of celiac disease of 0.8 to 1%. That means about 1,400 undiagnosed cases. In other words, for each diagnosed case, we have at least 3 to 4 undiagnosed cases that need to be found. If we look at the US population, the 308 million, we found a similar picture. And in this study, most cases remain to be diagnosed. From 35 celiac patients that were diagnosed, 30 didn't know about the diagnosis, and 14 have a clinical diagnosis, but only 6 were following a gluten-free diet. That means that about 1.8 million residents in the US are affected by celiac disease with a prevalence of 0.7%, and 83% remain to be diagnosed. If we look at in detail what we call the gluten paradox, only a minority of persons were diagnosed and following a gluten-free diet. We have 1.8 million that have celiac disease, but they don't know that they have it, so they remain untreated. And at the same time, it was very interesting at that time that we found that 1.6 million residents of the US were following a gluten-free diet for a reason not related to a diagnosis of celiac disease. And that is the paradox and the big problem. This epidemiology has been changing. It has not been the same in the past. You see here in the 1950s, only 0.2% of the US population was affected by celiac disease. And if you look at more recent times, it increases to 0.8 and 0.9%. It's a 400 times increased risk of the prevalence in the US. And more recent reports from Denver, for example, you can see the prevalence of celiac disease in that region is about 3.1%. And the same is happening all around the world. This is a study in Finland in 1978. The prevalence was about 1%. And the 2000s, the prevalence was almost 2%. A significant increase in the prevalence of this condition. And we can say without any mistake that celiac disease is a worldwide disease. It doesn't matter where you are watching us, celiac disease is important for your clinical skills. So, and this map, you can see that celiac disease is affecting all the continents with variations in terms of the specific seroprevalence by country. So this is what I call the new phase of celiac disease. The highest prevalence of celiac disease is in Africa, 5.6% in the Sahrawi population in the north of Africa. But if you think about this, there's consistent evidence of a prevalence of 0.5 to 1% in India. If you think about India population of 1.3 billion, there's a lot of celiac disease over there. And just as an example, in the US, the highest prevalence for celiac disease is in patients that are from the Punjab region in India. It's no longer white, non-Hispanic whites with the highest prevalence. And then if you look at all the studies that have reported incidence globally, 73% of the studies showed a rise in incidence of celiac disease around the world. This very interesting study from Sweden shows the rise in incidence in the 1990s to close to 2020, and then a plateau. You can see how the incidence is no longer increasing in Sweden, probably because they diagnose most of the patients. As you can see in this picture, the celiac to normal mucosal ratio is trending down, meaning that in Sweden, they're still doing endoscopy and looking for celiac disease, but now they are seeing normal biopsies because the rise in incidence has stopped. So what is important to remember is that to detect celiac disease, we need to think beyond diarrhea and weight loss. If you just focus on those two symptoms, you will miss the big pie of celiac disease. This is a multi-system disease, and we need to think about all these conditions that may be associated with celiac disease, gastrointestinal and extraintestinal. And that is the point of the current testing paradigm that is looking for celiac disease beyond the classic presentation, what we call case finding. And it's important to look into non-classic presentations like iron deficiency anemia, irritable bowel syndrome, infertility, osteoporosis, hyposplenism, dyspepsia, and also looking for the disease in conditions at risk for celiac or associated disorders like type 1 diabetes, Down syndrome, family members of patients with proven celiac disease, microscopic colitis, and others, and that we will review later. So the take-home points part of the presentation is that celiac disease is common. Think about celiac disease beyond the classic presentation of diarrhea and weight loss. And case finding helps to improve diagnosis in clinical practice. It's important if you think about the diagnosis to test for it, and that is going to be the point of the next presentation by my colleague, Dr. Jensen Noel. Thank you.
All right. We've noticed that some questions have come in, and I wanted to let you know that we'll address those in detail when we go to, when we finish up all of the talks, but before we do the cases. I'm going to chat a little bit about the diagnosis of celiac disease. How should I test? Here are my disclosures. The learning objectives tonight are to explain the current approach to the diagnosis of celiac disease, to describe proper biopsy practices for celiac disease evaluation, and to discuss the diagnostic challenge of a patient who is already gluten-free. Let's start with how to test for celiac disease. Current guidelines tell us that we need a combination of serology, or a blood test, and biopsy of the small intestine in order to make the diagnosis of celiac disease. The blood test is the tissue transglutaminase immunoglobulin A, abbreviated TTG-IgA, and this is the test of choice for celiac disease. This is felt to be greater than 95% sensitive and 98% specific for celiac disease, and it performs well in both referral and primary care populations. You must obtain a total immunoglobulin A level to ensure that the TTG-IgA is a valid test. And this is because we want to uncover any selective IgA deficiency. This is found in about 2 to 5% of patients with celiac disease, and it means that you have to use an IgG-based test to evaluate a patient. In summary, for the serology part, you need the TTG-IgA and the total IgA to be ordered for a patient in their workup of celiac disease. Let's look at this diagnostic algorithm for the evaluation of celiac disease in adults. First, we must verify that a patient is on a gluten-containing diet, as this helps ensure the accuracy of the testing that's done. As mentioned, we do the TTG-IgA and the total IgA. If the patient is IgA deficient, this is along the left side of this algorithm, we must move forward with an IgG-based test. This would be the TTG-IgG. If this is positive, you move forward with the upper endoscopy with biopsies of the small intestine. If this is negative, this makes celiac disease unlikely. If a patient has a TTG-IgA that is negative and a normal total IgA, celiac disease is also unlikely. But if you have a strong clinical concern for seronegative celiac disease, for example, if the patient has classic symptoms of malabsorption, like significant diarrhea and weight loss, it's prudent to move forward with the upper endoscopy with biopsies of the small intestine anyway. If the TTG-IgA is positive, you go ahead and do the upper endoscopy with duodenal biopsies. If those are found to be abnormal and show the characteristic findings of celiac disease, the increased IELs, or intraepithelial lymphocytes, and villus atrophy, this confirms your diagnosis of celiac disease. If those biopsies are normal and the TTG-IgA is positive, this represents potential celiac disease. And we suggest that you monitor this patient clinically, as they could be at increased risk to develop celiac disease. Now that we've talked about the serology, or the blood testing for celiac disease, let's talk about the histology, or the pathology for the diagnosis. Per the Oslo definitions, celiac disease is an immune-mediated chronic enteropathy, or disease of the small intestine, that occurs in genetically susceptible individuals after ingestion of dietary gluten. On this slide, we see normal small intestine histopathology on the left. The villi are projecting towards the top of the image and are normal and healthy. On the right, we see the slide of a patient with celiac disease, the hallmarks of which are villus flattening or atrophy, crypt hyperplasia, and expansion of the lamina propria with increased intraepithelial lymphocytes. These findings are needed in order to make the diagnosis of celiac disease. While it may seem relatively straightforward, the blood work and then the upper endoscopy with the biopsy being consistent with celiac disease, sometimes making a diagnosis of celiac disease can be quite difficult, and there are a number of pitfalls in coming to this diagnosis that I'd like to highlight. One of which is testing when the patient is already gluten-free, which we'll cover a little bit later in the presentation. Another is ordering a panel for celiac disease, and then confusion in interpreting the results when you're looking at some of the other antibodies, such as the deamidated gliadin peptide, abbreviated DGP, or the endomysial antibody, abbreviated EMA. Confusion here can lead to both under and overdiagnosis. And this is why we recommend streamlining things by ordering the TTG-IgA. You could also miss an IgA deficiency and the need for IgG-based testing, which we were looking at on the left side of the diagnostic algorithm. And another area of concern is forgetting to order the confirmatory biopsy or delaying the EGD, which could result in falsely normal findings and creating confusion about the diagnosis. My first key message of the evening is that the diagnosis of celiac disease requires both serology, the tissue transglutaminase antibody, IgA, and a confirmatory biopsy of the duodenum with the finding of villus atrophy. Next, I want to talk about biopsy technique, as this is an area for us as gastroenterologists to improve and provide high quality care for our patients. Research shows that about 39% of patients who are being evaluated for celiac disease had 4 or more specimens submitted or biopsies taken during the procedure as a part of their evaluation and sent to pathology. ACG guidelines recommend that we take 4 biopsies from the distal duodenum and 1 to 2 biopsies from the duodenal bulb. We suggest that the bulb biopsies are from the 9 o'clock or 12 o'clock position in order to avoid Brunner's glands, and the biopsies from the distal duodenum should be scattered and not adjacent to one another, as the findings in celiac disease can be patchy. The biopsies from the distal duodenum and the bulb should be placed into separate jars. This is helpful for the pathologist. And research shows that taking a single bite per pass with the biopsy forceps improves the orientation of the small intestine mucosa when the sample is processed in the pathology lab. There's a spectrum of findings that can be seen during endoscopy for a patient with celiac disease. And these can range from a completely normal appearance to the mucosa, which is why it's important that we biopsy and biopsy appropriately, to some of these findings shown here, such as the stacking of folds, scalloping, the mosaic pattern, or villus atrophy. These can become more apparent if you use water immersion to look at the small intestine. My second key message is that proper biopsy technique improves the diagnostic yield of the upper endoscopy procedure and increases the chance of finding celiac disease where pathology can be patchy. Now I'd like to talk about altering the diet in patients who are doing this when they come in to see you in clinic. Do not limit gluten prior to testing for celiac disease. This is important for patients to know. It decreasing gluten in the diet reduces celiac-associated antibody levels. The antibodies are dependent on the ingestion of gluten. And little is known about the precise dynamics of that reduction, but the change can occur as quickly as within weeks. We know that after about 6 to 12 months on the gluten-free diet, 80% of people will have negative serology, and after 5 years on the gluten-free diet, over 90% will have negative serology. So this is certainly impacted and can have an influence on the testing that's done. Also, changing the diet is not helpful from a diagnostic standpoint in terms of how a patient is responding to symptoms. So if they have improvement of their GI symptoms after removal of gluten, this has a positive predictive value of just 36% for celiac disease. A clinical exacerbation after reintroduction of gluten has a positive predictive value of just 28%. Neither of these numbers are particularly helpful for us when evaluating patients. So it's important that that's not necessarily a part of our workup or algorithm. Patients can have other conditions to think about that are related to gluten. So it can be something beyond celiac disease, like non-celiac gluten sensitivity, wheat allergy, or irritable bowel syndrome with fructose intolerance. Here is the other half of the algorithm for the workup of celiac disease for those following a gluten-free diet. You could begin with genetic testing to look for the permissive haplotypes. If this is positive for DQ2 or DQ8 or DQ7.5, which can be associated with celiac disease as well, we suggest that you have the patient undergo a gluten challenge or exposure or gluten holiday. There's no consensus in terms of the dose or duration of this gluten challenge. What we would suggest and do in our practice is about 6 grams of gluten, the equivalent to about 2 slices of wheat bread per day for a period of about 8 weeks. Then you move forward with the TTG IgA as well as the total IgA and the upper endoscopy with biopsies of the small intestine at the end of that 8-week period. And then you can make your diagnostic determination. If the patient is negative for the permissive haplotypes, then celiac disease is not likely, and you should consider one of the alternative diagnoses that we discussed before. My final message of the night is that the workup is different for those already limiting gluten in their diet. Consider a gluten challenge or genetic testing in this clinical scenario. Thank you for your attention, and I look forward to addressing some of the questions after we hear from our dietitian colleagues.
All right, thank you so much. I'm going to share my screen real quick. All right, and today myself and Kendra Weekly will be talking a little bit about some of the practical aspects of a gluten-free diet. So we have nothing to declare. The learning objectives for our talk are to just summarize the gluten-free diet for celiac disease, discuss what patients need to know about the food label, review some of the common sources of cross-contact, and highlight some of the social implications of celiac disease. I always like to start out by thinking big picture, what are the goals of putting somebody with celiac disease on a gluten-free diet? And the number one is always to treat the celiac disease. But if we just stop there, I think we forget a little bit about, the patient's overall health and potentially their psychosocial well-being. And that's where these other goals come in as well. Anytime we put somebody on a restrictive diet, we need to ensure that their diet is still balanced for their overall health. And we still need to promote a good food-related quality of life by doing things like limiting food-related anxiety, over-restriction, and really instilling confidence in our patients in how to properly follow this diet. Just a little bit of background on the diet itself. Gluten is a mix of proteins, and it is found in 3 specific grains: wheat, rye, and barley. And a gluten-free diet is a diet that's free of these 3 grains, plus any ingredients derived from these grains that still have gluten. Wheat is found in a bunch of different foods that are staples around the world and in the United States, like bread, pasta, crackers, pastries, and cereals. And the per capita wheat consumption in the United States in 2022 was 125 pounds per year. And so that kind of begs the question, how do we actually replace all of that gluten in somebody's diet? The first thing I always like to talk about with patients is, how do we actually avoid gluten? Because we have these umbrella grains, wheat, barley, and rye, but they can also go by a bunch of different names in our food system. Barley is often turned into something called barley malt, which still contains gluten, and there's a lot of different names that wheat goes by depending on the type. So einkorn, emmer, semolina, and spelt are all different types of wheat, and those are important for patients to be aware of. Now, once we figure out, how do we identify gluten in the diet, we have to figure out how are we going to actually replace it using these gluten-free grains and starches. And here it's really important to recommend a variety of gluten-free whole grains whenever possible. I think a lot of the times we get stuck on some of the easy ones like corn, potatoes, and rice, and there are some drawbacks to doing that. Specifically, a rice-centric gluten-free diet does put the patient at a higher risk for a high exposure to arsenic, which we know comes with its own negative health effects. We also have to consider the balance between gluten-free replacement products, which tend to be a little bit higher in saturated fat and lower in protein and fiber. And a big piece of following a gluten-free diet is finding the right balance between those and the variety of naturally gluten-free starches like buckwheat, millet, wild rice, quinoa, in addition to the corn, potatoes, and regular rice. Another big aspect of the gluten-free diet is patients are going to ask you, how do I know what foods are gluten-free or what foods are safe for me? And this really comes down to the patient's ability to accurately read a food label and identify what foods contain gluten. This is going to be different country by country, but for the United States, I'll kind of take us through the 4 things that I normally talk about as far as looking at a food label for somebody with celiac disease. The first one's going to be the FDA labeling law describing gluten-free foods. The second is the Gluten-Free Certification Organization symbol. The third is the FDA allergen statement. And the fourth is the FDA voluntary allergen advisory statements, also sometimes called precautionary allergen statements too. Now, looking at this FDA labeling law, this was put forth in 2013, and they issued a final rule defining gluten-free on any of the packaged food labeling. And they just mean that the food that states the food must not contain any ingredient that is wheat, rye, or barley, any ingredient derived from these grains, and the total food must actually test below that 20 parts per million threshold, which is the level that they deem safe for somebody with celiac disease. You can see an example of what this looks like on the Kraft mac and cheese on the right there, where it says gluten-free. Now, there is also this third-party certification from the gluten intolerance group. It looks on the right there like a little squiggly G, and it is a little bit stricter than the FDA standard. So they have a gluten threshold of 10 parts per million or less, and they also require any manufacturers to go through annual training and competency, on-site audit of facilities, and the product testing for this is actually mandatory, where for the FDA certification, it is not specifically stated that product testing is mandatory. There's also the FDA allergen statements, and this is just the FDA's requirement that any food allergen must be identified on the food label. Now, this only applies to ingredients and not cross-contact, so that's something to keep in mind. And if you look on the right there, we can kind of see wheat flour would be the first ingredient on that ingredients list. And at the very bottom, underneath the food label, the ingredients list, you'll see the contains wheat statement, indicating that wheat is one of the main ingredients in this food. Now, how I like to talk to patients about this is I always tell them this is a good way to be able to rule out a food. So if it says contains wheat, you instantly know, this is not a gluten, or this is a food that contains gluten and it's not gluten-free, something I should be avoiding. But you cannot use this to find a gluten-free food because barley and rye are not part of the top 9 allergens. And so even if the food doesn't say contains wheat, we still have to look through the ingredients list for barley and rye and malt, other gluten-containing ingredients there. Finally, there's this FDA voluntary advisory statement, and this is the FDA allowing for a voluntary labeling of foods with a high risk of cross-contact with food allergens. There's a lot of different terms that this can encompass, but it sounds like something like may contain wheat, or processed in a facility that also processes wheat, or manufactured on equipment that processes products that also contain wheat. So there's a lot of different ways that this can manifest on a food label. Important things to note about this statement is it is, like the title says, completely voluntary. So 2 manufacturers who produce on the same production line, one of them can put it on their product and the other one cannot, and it's completely up to them. And it does not actually mean that any testing has been done to the product. And so it's a little bit of a gray area when it comes to advising patients on a gluten-free diet. But my practice is if a food is labeled gluten-free and has one of these precautionary allergen statements on it, I still consider that safe for somebody with celiac disease. Now, if a food is not labeled gluten-free, but it has this advisory statement, we really have to tell patients that it's unknown or it's a gray area whether that product is safe. And we've actually done, or there has been a small pilot study looking at this, and they found that between similar products, one containing this statement and one not containing this statement, there was no increased or different risk of that product testing to more than 20 parts per million in gluten. Kendra Weekly is going to take over this part of the presentation.
So another really important part of the gluten-free diet is this cross-contact, right? So when you think of, okay, I'm now gluten-free, gluten intolerance, you get a burger and it has a bun on it, you can take the bun off and still eat that burger. In celiac disease, you can't do that because it has been contaminated or has been contacted with something that has gluten in it. So when going out to eat, when at home, when split households, it's really important to emphasize, that cross contact is still potentially gluten contamination. We want our patients to still feel like normal. We still want them going out to eat and enjoying those things, eating out at restaurants, social gatherings are around food in our culture. So it's really important to try to normalize some of those things, but emphasizing and empowering that patient to being the safest at that restaurant. So here are some common places where people would experience cross contact. One being shared fryers, pizza places, Asian restaurants, pasta dishes, Italian places that use a lot of doughs and breads, Shared preparation, like think of a hibachi like type of cooking space, salad bars, buffet areas. These are all very common places where you can have cross contact. A big culprit is those shared fryers. Next slide. So the shared fryers, now you might have a normal gluten-free food like French fries, right? French fries are made from potatoes. Potatoes are gluten-free. So in theory, these French fries should be gluten-free. But if you go to a restaurant and they are fried in the same fryer next to those mozzarella sticks or those, breaded chicken tenders, that oil is now going to contain gluten particles, and now that oil is on those French fries right next to it, and now those gluten-free French fries are no longer gluten-free. So we tell patients you have to ask to see if those fryers are separate, if there's a designated space where those are being prepared, like being fried. A lot of restaurants are incorporating separate fryers. So places like Chick-fil-A do have separate areas where they fry their French fries and then they fry their chicken tenders. It is really important to ask, and because, like Dr. Rubio said, the prevalence is increasing, a lot more people are asking about these things. So staff and chefs are a little bit more aware of celiac disease, gluten-free, and those types of precautions. But it is important for them to ask, which also can be one of those barriers, right? They feel stressed asking, servers, they feel it's a burden. So really emphasizing that that's important is empowering that patient to be gluten-free. Next slide. Some cross-contact at home. This is really important as well for families who live in split homes. I know a lot of my patients are like, oh, my kids aren't celiac disease and they won't eat those gluten-free foods. My spouse has his own, foods that they eat. So it's really important to also talk about how to be safe in your own home. So two big culprits here, appliances. You really only need new toasters, new air fryers. They're not required to get new ovens, refrigerators, microwaves. These are the two biggest appliances we like to replace. And I think that this is self-explanatory. The toasters, you can't possibly clean out all those crumbs. Air fryers use convection heat. So blowing of those gluten particles, even if you do clean the basket, can still be at risk for cross contact. You don't have to have any separate pots, pans, utensils. Unless we say it's super dinged up or scratched, we'd encourage them to replace it. I also encourage people to avoid or replace any wooden utensils or cutting boards because wood is porous, right? It expands and gluten can harbor in the wood. So we want to make sure that those aren't being used as well. And I always tell patients if they do cook a meal that contains gluten, to use separate sponges to clean those pots and pans and give it a double cleanse. If you have pasta gumpies in this sponge and you're wiping the pans and then you let it dry, it still might contain gluten. So then give it a different sponge and another cleanse, run it through the dishwasher if it's a dishwasher safe, and then they should be good to go. We do encourage separate condiments. So that's like if you tell your kiddo to go make a PB&J and they take their knife and they spread it on their regular bread and then they dip it back into that peanut butter. Now that peanut butter is contaminated or it has cross contact in it, some breadcrumbs, and it's not safe for celiac disease patients. So I encourage families to get any squeezy condiments so that there's no knives involved, but if they do have something that's spreadable, to have your own, put your name on it and separate it from, the others. And I think COVID's got us really good about washing our hands and washing our surfaces really frequently. And that's really important whether you're preparing your food, someone else's food, right before you're eating. It's really important to also just wash your hands and surfaces. Next slide. Some other considerations I like to talk with my patients as well is things that aren't food that might have gluten in it. So supplements, whether they're using protein powders, vitamins, minerals, it's really important to make sure those are also gluten-free. Lotions and sunscreens, while we know gluten is not absorbed through your skin, if it's on your hands and then you go to touch your food and that lotion has gluten in it, now your food is contaminated. Same things with chapsticks, lipsticks. While you're not eating those types of things, it is going on your lips and in your mouth, so that's important to be gluten-free. Toothpaste, mouthwashes, again, you're not eating it, but it is going in your mouth. Many of the name brands are gluten-free, but if they're using off-brands or generics, that's where we have to, look a little bit more in depth on their sites. Medications, specifically tablet forms, will often use like wheat or starch, like any sort of wheat starch to bind, those medicines together. And then pet food will often have wheat in it. So if they're feeding their pets, making sure to wash their hands after feeding them to avoid any, gluten on the hands. Next slide. We do like to talk about the social considerations, right, of being gluten-free. So we'll hear it a lot. Gluten-free foods are expensive, and how is that going to affect the patient and their family? Also social gatherings, family dinners, potlucks, work gatherings, picnics. How do you stay safe? How do you feel like you're not in a burden or isolation? Like, oh, my family has to choose a restaurant around my dietary restrictions. That might cause a lot of stress. The fear of cross contact is really important too. We're fearful around eating, fear around food, avoiding food because of cross contact. And then those split homes. I've had lots of patients tell me I have to cook 2 meals for my family because they don't want to follow a gluten-free diet with me. Next slide. So they did this small study, 80 teenagers and adults, and they just interviewed them and asked, how do you feel? What's your quality of life around following a gluten-free diet? All of these patients had tissue biopsy positive celiac disease, and those extremely vigilant, very intense patients had a lower quality of life because they were very fearful around eating, especially while eating out and going to restaurants. People who were a little bit, less vigilant or less intense about the gluten-free diet had a better quality of life. And just because you're not intense doesn't correlate with your compliance. You can still have a very compliant patient who is willing to be a little bit more like what David said about the guidelines, being a little bit more open to some of those other FDA statements and still have a really good quality of life without restricting as much food. So it is important to remember to discuss these things with patients and ask them, hey, how are you feeling? How's it going? Like, do you feel stressed about following this diet? How's your family support? How do you feel about going out to eat? Those types of questions are really important, for all clinicians. Next slide. So some big takeaways is that we want to make sure that our patients understand reading a gluten-free label. Like David mentioned, it's not always black and white as much as we'd like it to be. So really making sure they have a good grasp on that. Talking about cross-contact and when going out to eat and at home. Also really trying to get them to not over-restrict some of these foods and empowering patients to confidently follow a gluten-free diet with celiac disease should be our priorities. Thank you for your time.
All right, wonderful presentation, Kendra and David. Thank you both so much. We'll now dive into some of the questions that were in the chat. And let's start with Alberto. I have a question for you. What is the significance of a positive screen in at-risk populations who lack symptoms?
Yeah, that's a very, 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 very good question. I think it's important because of the fact of detecting celiac disease early. So what is helpful is to test these at-risk populations is to detect the disease. And if you commit to the testing and you have a positive serology, then the next step is to confirm the diagnosis of celiac disease. If they don't have symptoms, like the typical symptoms, again, we need to kind of think about celiac disease beyond just the symptoms, because if we just focus on diarrhea and weight loss, like the typical symptoms, then we are going to miss all these cases. But if you test, let's say, a family member, a patient with a proven celiac disease, and the serology is positive, then the next step is to do a confirmatory test to confirm the diagnosis. If the diagnosis is confirmed, then the patient has to go on the treatment with the gluten-free diet to prevent the complications of celiac disease. And it's not infrequent that the patients say that they don't have symptoms at the time of the diagnosis, and then when the patients start following the gluten-free diet and you do the follow-up visit at 3 to 6 months, they discover symptoms that they didn't know that they had. And some of the symptoms could be fatigue, those symptoms could be joint pains, oral symptoms is actually irregular bowel habits without the patient calling that diarrhea or constipation. And in general, patients note the difference of following the gluten-free diet. If we think about this question more in terms of the long-term implications of an early diagnosis, we can say that even for a patient that has no gastrointestinal symptoms, they can obtain the benefits in terms of survival and decrease of risk of complications.
That's very important that you mentioned that, Alberto, and I would comment that as well. In clinical practice, anecdotally, so often we have patients come in who say, you know, they were asymptomatic, but then at their 3 to 6 month follow-up visit, they're telling us, gosh, I didn't realize that I was so bloated before, and feeling better from that standpoint. Or sharing something else about abdominal pain. A lot of times they're normalizing things and saying, I just thought that that was normal, but I am doing better. So there may be some hidden things that you uncover there. Another question in the chat is, how long is needed to be on a gluten-containing diet before testing?
Well, that's a very, very good question, right? So the ideal is to tell the patient not to go on the diet until the testing is complete. But it's very frequent in practice that the patients come with the question of celiac disease and they already start a gluten-free diet. In that circumstance, the suggestion is to at least go into several weeks on the gluten-free diet. For if the testing is going to be serology, 6 to 8 weeks could be the best thing to do. If the testing is going to be a biopsy, we know that even with around 2 weeks on the diet, we can see the changes in the biopsy. But to be consistent, I would say 6 weeks will be the number of weeks that make us make a decision at the end of with the testing. What do you think? Because that's a controversial area.
It is. I tend to go with about 8 weeks on the gluten-containing diet. Sometimes I'll even send them to Kendra or David to chat a little bit about how much gluten they should be eating and to make sure that they're at least getting some gluten in their diet to get accurate testing for us. Kendra and David, when you guys see patients in clinic, what are you typically telling them for a gluten challenge or holiday? Let's give it a positive connotation.
Yeah, I think we really try to encourage, it sounds really boring to just eat 2 slices of bread every single day. So trying to find creative ways to get that 6 grams of gluten in to their diet really helps, I think, with compliance and sticking on that, especially if they're having symptoms and, it's not something that they're looking forward to every single day.
I always try to recommend the shortest duration, especially for patients having symptoms. So Dr. Jansen recommends the 8 weeks and definitely not a day over.
And we see a little bit of variety here with patients, right? Some people come in, you tell them, I'd like you to eat gluten and we're going to repeat your testing. And they're like, great, I'm going to go home and eat a pizza. And other people are very nervous about how they're going to feel on a gluten-containing diet. All right, one of the other questions in the chat is, when do you do genetic testing? Hopefully I covered some of that in my presentation, but this is a good thing to start with when a patient is already on a gluten-free diet, since it has a high negative predictive value. And it's also helpful when there's a discrepancy in the biopsy results and the serology results. This can be another role for genetic testing. Okay, we also have a question about ordering serum IgG when obtaining the serum tissue transglutaminase IgG antibody. We don't commonly order the total IgG because that's usually only seen to be low in common variable immune deficiency, which is quite rare. So typically, an IgG-based test alone is good enough without the total IgG.
And the other point is like IgA deficiency is associated with celiac disease, but IgG deficiency in that context, or the clinical context of a low IgG, is not associated with celiac disease. So then the risk is very low, as you say, but the risk to be low in IgA is increased in celiac disease. That's why it's very important to check IgA, and that is different between IgA and IgG.
Excellent point. Excellent point. All right, another question. Can you comment on tools like Gluten-Detect on helping patients follow a gluten-free diet? Kendra or David?
Yeah, I know that Dr. Rubio uses the Gluten-Detect often in his office, and this is a really great tool. Unfortunately, it's after being exposed, right? So it doesn't help us prevent an exposure, but it can kind of pinpoint if you've been exposed to gluten because it will show up in the urine. And they do have stool testing as well for Gluten-Detect. I think the urine strips are a little bit more like cost affordable, so we encourage those ones that are a little easier too. And I think they're very helpful tools, and you can kind of then backtrack, okay, what foods have I eaten in the last, I think it's 48 hours, correct? That that might have contained gluten, and then you can kind of weed that out in your diet.
Yeah, and I'll say, I feel like one of the most frustrating things for patients is when their TTG IgA remains elevated and they are really trying hard to follow a gluten-free diet. And this gives them the peace of mind of, is there actually gluten in their diet and is it showing up on this gluten detect? Or is it something like a, refractory style disease? That really helps with giving patients either that peace of mind or telling us, we need to do some more digging into their diet and really identify where that gluten contamination is happening.
Excellent. We haven't heard yet from Dr. Ford. He's going to be featured in the cases coming up. But Drew, a question for you. How do we know which pills have gluten?
That is an excellent question, and oftentimes it isn't so much the medication contained inside of them, but it has to do with the capsule material. And there's really not one one list you can rely on because different manufacturers make different pills. And the big question that you'll want to pose is where was my pill manufactured? And you can often ask the pharmacist to provide you clarification and give you connections if you need to figure out whether or not a certain pill is causing contamination when everything else is showing itself to be in good adherence. If somebody's adhering perfectly to the gluten-free diet, but they still have refractory symptoms and they're taking a lot of different medications, it could be valuable to connect with the pharmacist to look over that and see where that might be happening.
Excellent. Another resource that I'm sharing with patients lately as well is the NIH Daily Med, where you're able to look up the active and inactive ingredients in the medication and check those for gluten. Kendra and David, this is also your area of expertise. Comments, other thoughts?
I encourage patients to speak with their pharmacist if they are concerned about a supplement. The pharmacist has different tools, resources, numbers, like Dr. Ford said. So usually they're very happy to help.
And I just want to make a brief comment about that. I'm trying to, I know that it's important to know if gluten is in the medications, but probably the amount of gluten, even if there's some gluten in the pills, it's not enough to cause significant symptoms in the majority of the patients or problems in terms of healing of the intestinal mucosa. There's a few studies from Switzerland that they basically look into the amount of gluten in medications that they know contain gluten, and it was always below the 20 parts per million. So there was some gluten there, but not enough to really be a problem clinically. I think that as Dr. Andrew Ford mentioned, if the patient is having issues with symptoms it's very important to look into all of those details. But if the patient is doing well and is just taking the regular pills, I probably know, I probably will say, well, you are doing well. You don't need to kind of really worry about it. And that's kind of my approach, because otherwise people start being very over vigilant over all these issues, and it may affect the quality of life of the patients.
Let's end with one final question, and that is, does celiac disease that has positive bulb biopsies only have a different natural history than if the second portion of the duodenum biopsies only are positive?
Well, that's an excellent question. So that situation where the bulb is affected, but the distal duodenum is not affected, is called ultra short celiac disease, because it's just affecting a small portion of the duodenum. There is those patients are not different in terms of the response to the gluten-free diet as a patient with all the duodenum affected. Those patients tend to be younger than the patients that have all the small bowel affected. Ultra short is also associated with less iron deficiency anemia, and also in those patients, the serology, like tissue transglutaminase antibody titer, tends to be lower. But when those patients go into the gluten-free diet, the clinical response is not different. And as far as I know, there's no difference in terms of the risk of complications for those patients between ultra short and the regular celiac disease.
Wonderful. Let's turn it over to Dr. Ford for the cases and our panel discussion.
All right, thank you, Dr. Jansen. Let me just pull my slides up here. All right. There we go. So, yeah, my name is Dr. Ford. I am currently a fellow at Metro Health, and I'm so honored to be here and discuss celiac disease with you and do this exciting activity where we're going to take everything that we've discussed leading up to now and apply it to presentations of real patients with celiac disease across the spectrum of how celiac disease can manifest. So full disclosure, I have no disclosures. And we'll start with case number one. We have a 36-year-old woman who has mild IBS-like symptoms manifesting with abdominal pain and diarrhea. And her sister was recently diagnosed with celiac disease as well. She came into the clinic and the initial workup showed the following findings. We had a tissue transglutaminase of 65, while the cutoff is usually below 20. And then the duodenal biopsy on the upper endoscopy showed villus atrophy and increased intraepithelial lymphocytes, the two hallmark findings that you need to have at least MARS-3 histology, and as such, a diagnosis of celiac disease. So we have somebody who has very classically presenting celiac disease. And what I want to do is walk through now the process of how these patients progress after they start the established treatment of a gluten-free diet. So as our dietitian colleagues so expertly laid out, there are so many benefits to a gluten-free diet and celiac disease. We have, quite simply, the symptoms get better, as do the serologic and endoscopic findings. We also have improvements in overall quality of life. And we'll get into this a little bit more about the complications of celiac disease if left unchecked or if refractory even, but there's a decreased risk of complications when they have gluten-free diet, and there overall is a survival benefit, believe it or not. So the take-home point is gluten-free diet is key in these patients. So now I want to go through the progression of once you start the gluten-free diet, how is the patient going to get better? And it starts with the symptoms. The symptoms get better very early on in the course of starting the gluten-free diet. So sometimes within even a course of days, as Dr. Murray showed in the study here, even within a week, we see some patients getting better with their symptoms from celiac disease. And he was looking at the classical symptoms such as steatorrhea, diarrhea, weight loss. but this extends to the non-classical symptoms too. So it's profound how quick the symptomatic changes can occur. This can't be said for the serologic or the endoscopic changes, though those do take a little bit more time. So while we're in the case of days to weeks for symptoms, normalization of the serologies takes upwards of months. So the excuse me, the serologies, they can start extremely high, and they, after starting the gluten-free diet, and follow them up within a couple months, will start to come low. People who have a higher initial diagnosis, serology, will likely have elevated antibodies at their first recheck. People with a lower initial serology may be under the cutoff values, as you see with this graph here and from Dr. Mackman's study. But the moral of the story is that within months, you're going to start to see the serologic improvements. Now, mucosal healing, which is what we ultimately want to be seeing when we start somebody on the gluten-free diet, that takes years. So sometimes you'll go back in within 1 year and still see some scalloping, still see some villus atrophy, and it takes a bit longer. So this is, for instance, in the case at diagnosis, you see the scalloping, you see the effacement here, but after 2 years, we have very healthy looking duodenal mucosa. So the moral of the story is you don't want to jump too fast to a recheck endoscopy, but we do want to know if these patients are getting better endoscopically. So a lot of practitioners will do a repeat endoscopy first year after diagnosis. And sometimes you'll see improvements sooner, but usually it's about a year. So then the question comes up of how to follow these patients up. A lot of the time it's going to be with a standard gastroenterologist in the community, but there are dedicated celiac disease centers as this patient was treated at. And recent work that we've done to look at the care given at a celiac disease center versus standard gastroenterologic care shows that there are improved outcomes with respect to the symptoms, as well as adherence to quality metrics in the patients who undergo care at the celiac center compared to their standard gastroenterologic colleagues. And that could be because of availability of many different aspects of celiac care under one umbrella, such as dietitian, pharmacist, gastroenterologists specializing in celiac disease. But at the end of the day, we don't have these centers everywhere. They're only at a select few academic centers. So the question comes up of how can we provide this care to everybody that we possibly can, people with celiac disease in more rural areas who might not have access to these centers. So that is answered with very simply systematic. That is how we want to address celiac disease in the community, where we can't treat them necessarily at the celiac disease center. However, it is worth noting that despite many publications trying to find the best way to approach follow-up, there is no one consensus way to do it. However, expert advice would recommend at least components of the following, including the clinical and serologic follow-up on a monthly basis, repeat endoscopy 2 years, maybe even 1 year, but definitely within 2. Rechecking any nutritional labs that were aberrant in the initial diagnosis, and then bone density scans. These are very important aspects to the overall care of celiac disease. And then you might be wondering, what about other healthcare maintenance for celiac disease, and how does that differ from the general population? And the answer is vaccines provide a deviation from our standard care. And there are many vaccines that have shown beneficial in celiac disease. I'll highlight a couple here, but strep pneumoniae is a very large one. It's thought that celiac disease patients are functionally asplenic and do not have those same defenses against the encapsulated organisms. COVID-19, we even see benefit there. But I want to turn it over to Dr. Jansen here.
Excellent, yes. Vaccines are important to think about in clinical practice. Dr. Ford, you highlighted a lot of important ones. And I just want to point out that the new ACG guidelines recommend the strep pneumonia vaccination for all patients with celiac disease. So this is an important one to keep in mind, and an area where we can improve care for our patients.
Thank you so much. So you might be wondering what happened after we started the gluten-free diet, and I'm very happy to tell you that within months, the follow-up showed that she was improving symptomatically and serologically after starting the gluten-free diet. And so exactly the course that we would expect. Within months, you're getting both that serologic and symptomatic improvement. So what I want you to take home from this first case is that follow-up is a key part of caring for a patient with celiac disease. We don't diagnose it and then that's it. We have to be vigilant in watching how they're doing with this and try to catch areas where there may be lapses. We'll talk more about the potential lapses with case number 2. And then at the end of the day, there's no consensus on how to best follow up celiac disease, but incorporating the healthcare maintenance aspects that we discussed are going to be vital regardless. And just remember that progression of the improvement of celiac disease symptoms, serology, and then finally the endoscopy improvements. So with that, let's go to the second case for something a little bit different. Number 2, we have a 73-year-old woman who has already been diagnosed with celiac disease. This was 16 years ago at age 54. She presented with classical symptoms such as diarrhea and weight loss, as well as iron deficiency anemia. And she was on a strict gluten-free diet. She's been very adherent to it, and she's been doing well for years. However, she was referred to our center in 2019 with further diarrhea and weight loss of 20 pounds in 3 months. So this always begs the question, does my patient have refractory celiac disease? They state vehemently that they have been on a gluten-free diet, but the key things to think about are, do they have this persistent villus atrophy? Are there still symptoms that are consistent with celiac disease, despite excluding, most importantly, other causes of these symptoms, and making sure that those might not be at play? So we're going to go through a 3-step approach to these patients who have recurrent and refractory symptoms, despite their best attempts at the gluten-free diet. So the first question, was the diagnosis real? So we want to go back to the initial evaluation and look at the endoscopic finding, the histology, were there IEL and villus atrophy. We want to look at that and determine whether or not it's truly celiac disease. Now, in her case, it was truly celiac disease. So we can go to this next part, step 2. We know that celiac disease is present, and we know that celiac disease is best treated with a gluten-free diet, and refractory symptoms are most commonly caused by inadvertent gluten exposure. So we need to figure out how can we see if this patient is truly adherent to the gluten-free diet. So this is where we confirm adherence to the gluten-free diet. So her serology was normal. Tissue transglutaminase was 7, cutoff is under 20. And then the dietitian thoroughly went through possible sources of exposure and found none. And even glutaminogenic peptides were negative, both in the office and home for this patient. So I'm going to turn it over again for a question for the dietitians.
Yeah, overall, some of the big ways that we can kind of confirm adherence are we just do a pretty detailed review of the patient's diet, kind of checking for, is there any overt gluten exposure, eating any wheat, rye, barley products, or any big sources of cross contact that we can think of, going through, where are you eating your restaurant meals at, any shared condiments, shared toasters, things like that.
I think I also talk a little bit like, going through that in-depth, and I always try to tell them I'm not trying to food police. I'm really just trying to figure out what your exposures are. So I'm going to be a little bit nitpicky and ask about, things like adding, like, are these weird coffee creamers? Are you adding any, condiments? Are you eating in a different environment? Like, are you stirring your, I'll ask a lot of just bizarre off the wall questions that maybe will have some idea or some insight on where they're getting that contamination from.
Thank you so much. Yeah, as you can see, there are so many different components to ensuring that the patient is on a gluten-free diet, and so many things that are easy to miss, especially when you're not educated about this in detail. A lot of patients have the diagnosis a long time ago, and the knowledge just wasn't as vast as it is now about gluten, and there weren't as many opportunities for learning about it. So thank you so much for that. So there's just a little diagram there of what we'll see on those tests. But then the third step here, we've confirmed that they are absolutely not being exposed to gluten as best we can. So then the next question is, what else could be causing this? There are other things in somebody who has confirmed celiac disease. There are other things that can cause these symptoms. It's quite as simple as irritable bowel syndrome. There's an increased prevalence of IBS-D, for instance, in patients with celiac disease. You can also have SIBO, microscopic colitis, both of which are also increased in prevalence in patients with celiac disease. And of course, if you identify one of these, you treat them. I will say in this case, there were no such causes. So we went back in with an endoscopy to evaluate for signs of ongoing celiac disease, despite the adherence to the gluten-free diet. And as you see, there's an effacement of the mucosa here. There's some stacking and mild scalloping there. And here we see on the histology some villus blunting and increased intraepithelial lymphocytes. This is granularity right here. And Dr. Rubio, what are your thoughts on the endoscopy and pathology here in terms of what they show?
Well, this is kind of concerning for a patient following the diet strictly for so many years, and suggests that strongly refractory celiac disease in this context, especially with the patient being symptomatic with diarrhea and significant weight loss.
Indeed. So this brings us to the next step. We have refractory celiac disease in this case. It's refractory to the gluten-free diet, and this is a serious complication of celiac disease. It is associated with high morbidity and mortality, and it can be characterized as two subtypes, which are extremely important to prognosticating and understanding what the next step will be. So the short is that refractory celiac disease 1, there's no polyclonal intraepithelial lymphocyte population when you look at it under the spectral staining. We'll talk about in a sec. While refractory celiac disease 2, there are those aberrant clonal populations, and refractory celiac disease 2 has an increased association with intestinal lymphomas, for instance, and then there also is a worse prognosis overall for patients with refractory celiac disease 2. So to make this distinction, as I mentioned, there's special staining that we need to do. We need to look at the immunostaining for markers such as CD3 and CD8. We also have to look at rearrangement of the T cell receptors. And then we want to look finally with flow cytometry. It's a three-pronged approach to making sure that we can see which subtype of refractory celiac disease this is, given the prognostic implications. So in her case, we did immunostaining and showed CD3 positive and CD8 negative cells, which are consistent with the aberrant population. And the flow cytometry further showed the aberrant IELs. And then last but not least, we have this aberrant clonal rearrangement of the T cell receptor. So this puts us in the camp of type 2 refractory celiac disease. This is a little slide on flow cytometry. I don't expect a full in-depth reading of this by anybody here, but the take-home points here are that some of the key markers that you'll see in the flow cytometry for patients with RCD2, you have CD7 positivity, surface CD3 cell negativity, while the cytoplasmic CD3s are positive, and the accepted cutoff for this population is roughly about 20% of all lymphocytes. So this brings us back to our algorithm. We've confirmed that this is type 2 refractory celiac disease. So we're on the right side of this algorithm. And you'll see here that both types, they merge here at this first line of open capsule budesonide. We'll talk about that very briefly in a sec. But first thing I want to point out this unique portion of the type 2 refractory disease, which we have to look for other concurrences with the type 2 disease, such as ulcerative jejuditis and enteropathy-associated lymphoma, both of which can further worsen the symptoms of refractory celiac disease, are associated with it and can carry worse prognosis. So with that said, we did some further evaluation, and we see some lab work that is consistent with ongoing malnutrition, malabsorption. The CT enterography showed a thickening of the jejunum with no obvious lymphoma, and then the capsule endoscopy showed diffuse signs of atrophy. Additionally, we did an enterography further, and we saw greater than 3 ulcers that were larger than 5 millimeters in this case. They were in the proximal jejunum, and this was indicative of ulcerative jejunitis. This carries a high risk of progression to lymphoma. And you can just see here that it's a very irritated looking mucosa that you see with the jejunum there. And it's a very poor prognosis that this carries, but to go to the management of both types of refractory celiac disease, we start with budesonide open capsule. So basically, you're going to open it and put it into something like applesauce and take that. And then we also have nutrition support. We need our dietitians' help to make sure that we are keeping up with the micronutrients and all the important things, keep things going. And you'll see here that there are some second line options depending on the phenotype, depending on age. There are different agents in both RCD1 and 2 that can be helpful, but we start with open capsule budesonide. And this just outlines the findings of Dr. Mukawar's study in 2017, where we looked at the patients who got open capsule budesonide. Notice that both types respond very well to open capsule budesonide, at least in part. Complete response in both is a little less frequent with the open capsule budesonide, but still very encouraging numbers. And so we'll go back to our case just to conclude things here. Started budesonide with open capsule. So you'll see here, it's a very long taper, starting with 9 milligrams for 6 months, and then going to 6 milligrams for 6 months. And then you do a maintenance dose from there on out of 3 milligrams. So very prolonged taper down to 3 milligrams. And of course, we provided nutritional support as well. And with all of this, we got an improvement in the weight again, and the albumin came back up from the 2s to the 4.7 now. And most encouragingly, the repeat biopsy was improved after all of this. So refractory celiac disease is extremely rare. You saw some of the numbers in that study. We're talking about teens, and this is at a center that sees a lot of very rare diseases. So extremely rare, but we want to start with open capsule budesonide once we've confirmed with that 3-step method that we have arrived at refractory celiac disease. We have to classify it correctly because of the prognostic implications and just overall treatment plan. And the take home here is that RCD2 is associated with a poor prognosis. Thank you so much for your time.
Wonderful case presentations. Thank you, Dr. Ford. We'll now bring up the closing slides, and Dr. Rubio Tapia will give some final remarks. Thanks for sticking with us to the end.
Yeah, thank you very much. We can talk about celiac disease for the rest of the day, but it has to come to an end. Thank you so much for your attention. The next live is about anorectal disease, evaluation and management in August 14, 2024. So stay tuned. Thank you so much.